Hello, Robert Bastian here of Bastian Voice Institute and Laryngopedia. My subject is conation in medical practice, and I'll tell you right off the bat that this is a low fact finder presentation, and you're going to understand what that is in a few minutes. So, a low fact finder presentation on conation in medicine. So let's go straight to a PowerPoint. Conation also could be described as instinctive striving, a person's instinctive striving, conation in medicine. And the formula that I'm using is that described by Kathy Kolbe, Kolbe, and you can go to her website if you're interested. And the thesis is that how each doctor practices medicine depends not just on their fund of knowledge, their intelligence, their personality. Those things certainly affect how they practice medicine. Culture, people in France, England, and the United States may do different things for the same circumstance because of their culture. And resources is also an impactor. If you're in a low resource environment, you will make different decisions medically than if you're in a very high resource setting. But I would say that conation appears to me to be one of the stronger influences. And so the caveat is that this is a thought experiment, and it's a low fact finder thought experiment. It's a big picture presentation, not a detailed granular presentation. And the disclaimer is that I have no connection to Kolbe. I am a fan, but I simply am a user and a fan. I have no connection to them. And of course, they may disagree with what I say here, or they may say it's unnuanced or whatever. But so what is conation? It's an old term. Merriam-Webster says it's the inclination. We lean into an instinct or a drive or a wish or a craving to act in this way rather than in that way. So it's that inclination. It's the inner vitality. Where is the inner vitality that causes me to engage and persist in a certain course of conduct? It's kind of will. It's not the same as cognition, emotion, personality, or strengths. Gallup Strengths Finder I happen to really like a lot too, but it's not any of those things, though there of course is some overlap among those things. It's the inner motivation towards acting and persisting. And it's hardwired for each individual, and it's unchanging. From birth to death, you can't change it. You can know it and understand it and perhaps mold it or shape it at most, but you really can't change it. Everybody has their own very persistent, durable, cognitive profile that they can't change, but knowing about it and managing it is really fun. Well, what are the domains of conation? This again is from Kathy Kolbe. Fact finder, that has to do with the way we lean in towards information. Do we lean to simplify and sort and discard detail, or do we lean into complexify, to add, tell me more, let's make this more granular? Is it forest or is it trees? It doesn't mean that a person who is low fact finder is unable to deal with detail. They may be just as able to deal with detail as a high fact finder person, but it has to do with the way they handle that detail. Is not to keep it all in suspension all the time and keep growing it, but it's to kind of shed what it seems to be irrelevant or not useful at the moment. Simplify or complexify. Follow through is the instinct to organize and complete. Is the person really inclined to systematize, check boxes, cubby holes, closing loops, finishing, or not? A person who says, I can do it a different way every time. It doesn't bother me to do things differently each time. And I don't feel compelled always to finish things. Quick start is the instinct to improvise versus staying with what is tried and true, the proven. It has to do with risk and uncertainty. And implementer, I've never liked the name implementer because it suggests put into effect, like follow through. But what it means instead is there are people, implementer, it has to do with the implement itself. So people who want the concrete, they want to build and see and feel and climb and take apart and put together, or they're more visualizers, they're more head workers. So if you go to a landscape company where all the people are there because it's their preference, they took themselves in that direction. It wasn't the only thing they could find to do, but they actually followed their own leading to become a landscaper. Then you would probably find implementer high level of implementer. I imagine it might be the same for a person who is really into athletics. It might, in terms of a trend, it might be the same for an orthopedic surgeon as compared to a medicine doc. So I don't know that, but I'm just guessing that the high implementers might be the orthopedists, the landscape people, the athletes. So to visualize or to concretize, head versus hand work. Now, how is one ranked on each domain, and what does one's rank mean? Well, each domain is represented by a 10-point scale, and Kolbe represents them as cylinders rather than just as a linear, a Likert kind of scale. And if you rank as a 1 to 3 on the scale, you are resistant. So I am a resistant fact finder. 4 to 6 is accommodating, and accommodators are very useful if two people are working together who are opposite. If you have a low fact finder and a high fact finder together, there can be some conflict because they approach information so differently. And the accommodator, if there's one in between them, can kind of go this direction or that direction, so they're kind of useful people. 7 to 10 is insistent. They just lean towards high fact finder or high fact finder, for example. They almost can't help themselves. It's always, well, tell me more, make this more granular. So what I'm going to stick with mostly is the fact finder domain. Again, there are the 4 of them: fact finder, follow through, quick start, and implementer. And these are my numbers, my personal numbers: 3, 4, 9, and 3. So I'm giving you a low fact finder presentation right now, not because I've decided to make it low fact finder. It's just the way I go at teaching and making videos. It's low fact finder. Big picture, structure, framework, rather than granular. I'm a maintainer, I'm accommodating. I am actually one who often creates the systematized process, but I'm not the one who wants to actually do the systematized process. I don't want to fill out the forms. I'll create the questionnaire and do all the detail, but because it's all relevant, none of it is irrelevant. So that's why I can do detail, even though I'm low fact finder. But I hate being the one who fills out the forms. That's just not me. I'm very high in quick start, which means I have a high tolerance for risk and uncertainty, and I am not that interested in doing things always the way they've been done before. Certainly if that's logical and makes sense, but if it isn't logical, then I'm quite happy to strike out in a different direction. I suppose in 2003, I was a full professor with tenure, and I left to form Bastion Voice Institute in 2003, and I suppose that was a reflection of my high quick start, my 9 quick start. I didn't know it at the time, but that probably explains why I was willing to take that huge, huge risk. And then I'm a 3 on implementer, and that surprised me when I first saw it because I'm a surgeon. But then I got thinking, well, surgery is really a conceptual thing that is activated in concrete ways, but it first is visualized. And so I think that's why maybe the interaction of the high risk capability and the visualizing side of surgery explains why that worked for me. So what I'm saying is that these instinctive strivings are the most potent interpersonal effect, more than personality, strengths, intelligence, and interest, I think. Now, others may disagree. Well, let me give you an example of how does my low fact finder manifest itself. Here's an example. For 15, 20 years, I used to give courses. I gave 4 or 5 different courses, but at the American Academy of Otolaryngology meeting every year, one of them I taught for many years was sensory neuropathic cough, because it was a very underserved diagnosis, and actually it was a little bit of my discovery. So sensory neuropathic cough I taught for a number of years, but it was a low fact finder course. It was big picture, it was strategy, it was framework, it was recognition, it was observation. Each year I noticed that there was this polarity, there was this duality of response to my course. Here's an example. One year a person said, in 25 years that I've come to the AAO, this was by far the best course I've ever attended. I can actually use this information. So I thought, well, that's a nice comment. I appreciated that comment. But same year, same course, same information, same presenter, and look at this comment. What a disappointed. I wanted a detailed review of LPR, reflux, asthma, allergy, and only 3 references, no comprehensive bibliography. So you see the duality, the polarity of those 2 responses. So after I became acquainted with Kolbe, this began to make sense, because I said, well, I'm low fact finder. The first comment might have come from another low fact finder person who sort of got me and understood the sort of way that I teach, and the sort of way I handle information and want to transmit it in a simplified kind of form. And the second comment might have been from a research-oriented person. I sometimes divide doctors between physician scientist and physician clinician doer. And so if that person is very much of a clinician scientist, and maybe even a PhD researcher, because I don't know who it was that said this, you can see why they would find my course disappointing. How does this apply to my teaching videos, especially on diagnostic model, on sensory neuropathic cough, and on retrograde cricopharyngeus dysfunction, RCPD, the no burp? Well, in each of those areas, I have taken a lot of trouble over a lot of years to simplify the information, to make as much as possible prima facie, to be logical about testing. And the answer is, I don't do any testing. A lot of them have already had tons of testing, and it got them nowhere, so that's one reason. But the other reason is that it's not necessary, and I can justify why I don't do tests. Imagine, so you see, my low fact finder is oriented to getting the patient somewhere better, quickly and efficiently, spending no money that's irrelevant. That's why the caseload for RCPD December of 2024 in our group here is nearly 2,000 patients. That's why sensory neuropathic cough also from many states around is at least 1,500 people, sensory neuropathic cough, because we don't do any testing. It's not necessary. We can explain why. But the high fact finder, the doctor scientist type, is going to find that completely unsatisfying. But you have to measure. You have to prove that. And so you see how there is what's called cognitive conflict between me on the low fact finder side and the very high fact finder physicians. I don't think either side is wrong. The high fact finder people will do much better at at research and publication than I ever would, I'll see far more patients than they will and develop a much bigger caseload, but I won't be the one who gets the respect surrounding the disorder because I won't have the measurements. I'll be living more at the level of observation, which is what I think is the potent and useful approach to these disorders. Now, so you can apply this to all these disorders, and I don't want to forget to say it matters a lot for the physician-patient interaction. Just one quick example, somebody maybe with sensory neuropathic cough and they've seen 3 doctors or 6 doctors and they've done chest x-rays and bronchoscopies and everything under the sun, and they come to me, and I'm going to take a low fact finder approach, and I don't need their tests, but they've had them all done, and nobody who's done all those tests has gotten the answer. They've done measures, they've done blood tests, they've done pulmonary functions, they've done chest x-rays, they've done CTs, and they still don't have the diagnosis of sensory neuropathic cough. So now they come to me, and I'm going to be able to tell them within minutes that this is what they have. But how does that read to a patient who's gone through all of that medical mill thing, but in addition, that patient is high fact finder? They're going to come to me saying, this doctor, meaning me, this doctor I'm going to make this doctor take every single straw off the haystack one by one until we find the needle in this haystack. The problem elsewhere is that the doctors didn't find the needle in the haystack. And I'm here saying it's not that haystack, it's this haystack over here. But the patient, can you see the conflict that can occur between the patient, the low fact finder doctor, me, and the high fact finder and medically jaded patient? So because I know about Kolbe, Kolbe serves as an agent in my mind between me and that patient, and I can get through that encounter far more comfortably because of the agency of Kolbe in my head. So when I recognize that I'm up against a very high fact finder and disgruntled kind of patient, what I say to them is something like this: well, Mr. Smith, you've brought me an awful lot of information here. It's a lot of detail, and detail is often good and necessary, but right at the moment, it's our enemy. And Mr. Smith kind of looks a little surprised. I say, it's our enemy because it's getting in the way of our getting to the heart of the matter. And so I'll say to them, would you permit me to take you through a line of reasoning that will establish the foundation and the framework, the headline, the sort of overall understanding, the big picture understanding? I need to establish that framework, and then we can hang onto that framework any amount of detail we want to. But would you let me take you through this? And he will sometimes and so I'll begin through the questions, the most important questions, and maybe he'll begin to try to interject detail again, and I'll say, well, thank you, and I'm happy to get to that question and that information in a minute, but do you mind if we just finish? I'd like to just finish. I'm kind of halfway making this framework that I talked to you about. When we get the framework established and I begin to explain, the need for detail on the patient's part begins to melt away, and the need for detail, for me to deal with that detail, begins to melt away. So it was Kolbe, it was conation that helped me understand what was the initial little struggle between me and the patient. I don't mean that the patient would have seen it as a struggle, but I saw it as an impending struggle, a clash of conation. So it's very useful in the physician-patient encounter as well. Well, this is a meandering and, like I said, a thought experiment. It's low fact finder. Some people watching this are going to be saying this was too simple or it was too conceptual, but I hope at least it helps some people, gives you some food for thought. And in that spirit, I thank you for listening.